Thank you, Dr.Suven Bhattacharjee, for including me in your course. I think this is the 5th year in a row this course is running. My topic is iris hook, pearls and pitfalls. I have no financial interest to disclose. The small pupil which needs treatment. Which small pupil needs treatment before phacoemulsification? How small? This is the main important issue. So far, up to the 2002, this kind of paper was published, all kind of peer review journal, the tricks and tips of phacoemulsification with small pupil, how to regulate your parameters in the phaco machine, how to learn the vertical chopping in the central position. The all technique that is described and published in the peer reviewed journal. But the game scenario changed when Dr. David Chen described the IFIS syndrome in 2005. So categorically, if you divide the small pupil, it is a two category of small pupil. One is elastic pupil and one is rigid pupil. So if you consider the elastic small pupil or elastic IFIS syndrome, every pupil can be small. Even your 8 millimeter dilatation came down to 2 millimeter dilatation during your surgery with slightest of antechamber fluctuation. Then other side, the rigid pupil, whatever you do the maneuver in the surgery, your pupil size will remain same. So you can try all viscomydriasis, you can do the vertical chopping, but in case of IFIS, you need to treat your pupil before going to the phacoemulsification, because it may come down with slightest of axis fluctuation, slightest of chamber parameter change in your phaco machine. So can you say this is a diagram you can see? Can I have the pointer please? This is a two scenario when your pupil size is small and your rhexis margin is larger than the iris pupil size, and another your pupil is small, your rex is also small. The two scenario, the whole dynamics of the antechamber fluid is different. If it is a rigid pupil, it will not happen if your rhexis margin is larger than the pupil. But if it is an elastic pupil, it is elastic pupil, that if your rhexis margin is, rhexis size is larger than the pupil size, the fluidics can hit the iris and the pupil will come down within a minute into the 2 millimeter pupil. So this is very important. And for IFIS, you have to do a smaller rhexis, smaller than pupil size. This is a key factor, key word during the treating your small pupil. So there is a lot of deviate hook by this ring. The hook, the fundamental is it fixes the iris or pupil with the limbal ring. So it is the strongest to fix the iris or pupil margin, and the ring is only support the pupillary margin. So in case of severe IFIS, if you can expect, you can use it's a iris hook is always better than the ring. The Macul described in 1991, that time it is a titanium one hook, and later it is reusable Dejon in 1991. And I think everyone knows how to use iris hook now. Self-sealing stand incision in the limbus. Incision should be made posteriorly as possible, otherwise it gives a tenting effect. 5 flexible stools, sub-incision is very important. AC should be filled with viscoelastic, synoconagresis or pupillary membrane peeling before the iris hook, because otherwise it can tear the margin. Small amount of viscoelastic under the iris is the key, and it is very, this picture you can see that's how if you put the more corneal iris hook, it will tend. So it is the ideal one is this, you have to put the iris hook in the limbus. I am showing there's a small video. Can I run the video?
You can click from here.
Okay. Those who are just started, you can mark your position of iris hook with the pen, marker pen. This is those who are starting, and this is a very simple. Just engage the margin and keep it there, and tightening of the hook. After engaging all the hook, then you can tighten the hook. So this is a very simple technique. I think everyone knows how to use the iris hook. And removal of the iris hook also very easy. Just this is a small clip. Just turn around the hook, the either side, just either side. It will comes automatically. So it gives it needs 2 minutes extra to treat your small pupil before emulsification. Compared to other device, it is a low cost, better availability. You can reuse it, and dealing pupillary miosis after rhexis. This is a very important stage when you can. It's the iris hook is better than the any pupillary device. And disadvantage is only time consuming. You need extra paracentesis, and this is the most disadvantage point: dislodgement of hook during the phaco, because the long end of the iris hook can touch the adnexa, and it can dislodgement of the hook during the surgery. This is a particular case. I started the pupil size was more than 5.5. and suddenly it's come down because it's a IFIS, and I plan this particular case. I always prefer iris hook over any pupillary device. This is I borrow this video because I thought it is a very important and relevant to the topic. This is a very small from Dr. Roger Paul. This is small pupil. He started rhexis. During the rhexis, the pupil come down and he feels little bit of subluxation or genuladations during this stage, and you want to do the larger rhexis in this particular case. And this particular case, iris hooks is more rational to use iris hooks rather than any pupillary device. And in case of subluxation, if you genular, in case of if you feel that this case may have some kind of genular problem, it is better to use iris hook rather than the pupillary device. You can dislodge your iris hook and you can catch the rhexis margin. This particular case, I am started with the hook in the pupil, but I dislodge the hook and catch the rhexis margin to continue my phaco, because there is some sort of a genular problem in this particular hard case. I catch the iris and rhexis margin together with the iris hook. So if you my preference in all cases, I use yes, in our hospital we use pupillary device. All cases I use the pupillary device because it needs no avoid extern. But this particular two case, I always use iris hook. Preoperative, paroperative myosis and expected genular laxity, or planning to implant, I will in the sun class. Thank you very much once again, Dr. Suven, giving the